So here's like a clue, ladies. If you have to use a supplemental hormone, I don't mean in the beginning, like if you've been in menopause, we want to get a jump start on getting the genital urinary syndrome back in shape. But I'm talking about like for maintenance, okay? If for maintenance, you have to add a vaginal hormone to maintain vaginal pelvic floor, bladder health, then clearly your systemic level is inadequate. That's like a clue, right? Does a typical healthy 25-year-old woman who's having natural cycles need to take vaginal estrogen? I don't think so.
What do you do personally with your hormone therapy? I'm assuming you're on hormone therapy, but because you know how to do this, I'm not saying every woman should do just like you, but out of curiosity, I was going to ask you what you do with your patients, but why not you? How do you rhythmically or use your hormones?
Well, I'm always trying a little bit of different things. And I'll tell you that I'm at a crossroads of reevaluating a lot of the progesterone issues as well. I have used every product on the market, just so you know. So,
I can imagine.
I'm not like intrinsically at all against the commercial products. It's important to know that the commercial products are bioidentical when they say estradiol. And there were other ones on the market that have left the market because of lack of, I guess, a market share. And in terms of what's out there, and patches are sort of the mainstay of the bioidentical hormone estradiol delivery system because they're the most commonly used. They're commonly covered by insurance. And money does matter. For a lot of people, it really gets so pricey when they use the compounded products. So I try to make sure that I help people live within their budget. So that the estradiol patches are definitely something that people can use. I have certainly used them in the past on myself. Some of the problems that I'm seeing with the estradiol patches, they're pretty much all generic now. You can get Minivel sometimes, but it's very difficult to get a branded product. The vast majority are generic. Some of them have names, but they're generic names. What happens with these generics, but it can happen with the branded too, but it's even more with the generics, is that the amount of estradiol they deliver, the patches are supposed to last for 3.5 days, kind of a weird number, 3.5 days to be twice a week. And the amount of estradiol they deliver into the woman's bloodstream is more on day 1, less day 2, less day 3, and less even so on the last half day before it's replaced. For some women, they have to actually replace them more frequently, which insurance companies don't really care for. So I do have a backup system I can share. It's called the Hormone Club, where you can, and also GoodRx, where you can sometimes get discounts if you have to purchase them outside of the insurance plan. Because for some people, this 3.5 days, it doesn't last. The patches that are supposed to be for 7 days, they never last for 7 days. So I never ever use those. And the other problem with the patches, for many women, they don't deliver enough estradiol because they were all designed and produced during the time when the mantra was the lowest dose, not the most efficacious, the healthiest, it was the lowest. So even the highest dose patch for many women is not going to deliver enough estradiol, depending on how they absorb it. So the problems with the patches can be that they don't really deliver enough estradiol for the full length of stay that they're supposed to be on the body, and they also may not deliver enough. With the gels, there are 2 gels out there. They also don't go up very high in dose. So for some women, even using the highest amount, it doesn't deliver enough. But sometimes it does, but sometimes it doesn't. Some people complain they're kind of sticky. You can't put them on your face. They're alcohol-based. So there are some limitations. They also go in areas where people sometimes worry about what's called transference, that a pet or another human may touch them where they put the gel, and then some of the estradiol goes to that other person or pet. So that can sometimes be another concern, which doesn't happen with a patch. So I've tried all of these things, so that there's nothing like trying things so that you can discuss it best with your patients, the pros and cons. But those are the things that are most covered by insurance. And for some people, we really have to work with that. And then we can also get discounts through GoodRx and through the Hormone Club. Currently, I am using, and have been for quite a while, the compounded creams, but I've mixed it up with the progesterone, which I'll share in a minute. In terms of the estradiol, so I'm sort of, like you said, biohacking myself. When I used the dosing regimen that originally were recommended through the rhythmic, like with the Wiley, the dosing, for me, they gave much too high of a dose. I had periods like there was no tomorrow. It was like a little bit like a bloodbath, but it's individual. I obviously am a better absorber. I don't know if that's good or bad. Maybe my skin is thinner. I don't know what that exactly, we don't know what that means. Really, I can give the same estradiol cream dose to 10 women. They get totally 10 different levels into their bloodstream. That's the talk about personalization. So I think I am a very high absorber. Other people, I keep pouring it in. It's like it just doesn't, it's so hard to get in. It's like, well, let's try to put it here. Well, let's try to put it here. Let's concentrate it differently to try to get it through their skin. They have a real barrier. Mine apparently is more like a sieve. I get it in. It's like, whoa, what am I? Look at these levels I'm getting. So I had to really tone it down. So, but this is the kind of thing where we talk about every woman is going to be her own N of one, because how she absorbs when we use whatever product it is, whether it's the patches, the gels, the creams, and then there's a vaginal ring, which only comes in 2 doses, and that's hard to get. It's never really become very popular, but that there, just so you know, there is also a vaginal ring, but there's not a lot of flexibility with that because it just comes in 2 doses, one definitely too low, and the other one maybe it's okay, maybe it's not. But in terms of like how you dose it, it's really, oh my gosh, you really have to follow. If you have a uterus, what kind of periods are you getting? That's a good marker, and getting levels and so on. It's a lot of labor intense. That's why most doctors are not going to do it, including patients. Most patients don't want to have such labor intense work. But the reality is that if you really want optimal results, you got to put in the effort here. If you do the default, which is a little tiny bit of estradiol and then nightly progesterone pills, I can guarantee you are not going to get optimal benefits. You will get some benefits. I don't want to say that it's completely worthless, not at all. You will have some benefits. We know that it can help completely eliminate night sweats and hot flashes. Fortunately or unfortunately, depending on how you look at it, it takes only like a whiff of estradiol or any estrogen product to alleviate night sweats and hot flashes. Even a little bit of estradiol seems to slow bone loss. It won't grow bone and it won't give you optimal bone, but it will slow bone loss. So that's a good thing, even with static dosing. So there are benefits. You're not going to get optimal benefits for your brain and for your joints and for your cardiovascular system, for your genitourinary system. That's why all those women, they tell them you have to use vaginal estradiol or estriol if they're using that, or DHEA, but you have to use a hormone intravaginally because the doses they're giving are so inadequate to the task. So here's like a clue, ladies. If you have to use a supplemental hormone, I don't mean in the beginning, like if you've been in menopause, we want to get a jump start on getting the genitourinary syndrome back in shape, but I'm talking about like for maintenance, okay? If for maintenance, you have to add a vaginal hormone to maintain vaginal pelvic floor, bladder health, then clearly your systemic level is inadequate. That's like a clue, right? Does a typical healthy 25-year-old woman who's having natural cycles need to take vaginal estrogen? I don't think so. She's like totally fine in that department. So if you're 55 and you have to, because the dosing that you're getting systemically is inadequate, then it's inadequate for everything, okay? That's a clue. If you can't optimize health of your vaginal tissues and bladder and you have to use extra, what do you think is happening in your brain and in your bones and in your arteries and in your heart? Come on, it's like one body. If it's not enough for one part, it's not enough for the other parts. But when you do a more physiologic dosing and you get the levels up to somewhere, this is like the ballpark, somewhere in the neighborhood of what a healthy 25-year-old woman would have in her menstrual cycles, you do not need extra vaginal estrogen. Every organ system is getting adequate amounts. That's another good clue. So we have the period as a clue, like does it seem like a normal period? Not too little, not too heavy. How's your genitourinary tract doing? If you're having a lot of bladder infections, you're developing incontinence of any sort, incontinence like stress incontinence, urge incontinence, you have vaginal dryness, you do have painful intercourse, clearly your hormone levels are not up to the task. They're inadequate. In terms of, I'm using a little bit of rhythmic. I'm not doing the full thing, which I did. I did for quite a few years. I did the full-on Wiley type protocol. And it was like too much for me personally, the levels, the doses. I had so much breast tenderness. I checked the levels, they're too high. I dosed it down. And then what I tried to do, and I'm still like biohacking myself, is go up a little bit in the luteal phase. We know that when you make progesterone in a normal menstrual cycle, the estradiol levels are higher than they are in the follicular phase. And that's probably because progesterone downregulates the receptors of the estradiol. So nature puts out a little bit more estradiol to help counter the counter effects of the progesterone, which of course is not being ever going to happen when you're on these tiny doses of estradiol every day with the constant daily, nightly progesterone, because it's like beating down. The whole point of that is that you don't bleed. It's like you're giving the estrogen and then you're trying to negate its effects by giving the progesterone every night and giving such a tiny amount that it will never create any growth factors, which you need if you want to maintain tissues. So that's why I'm so anti that tiny dose static thing. But in terms of a normal menstrual cycle, you have the lowest levels during the period of estradiol, and then it rises some, then you get a big spike that triggers ovulation, then you get an LH spike, and then you ovulate, you get a dip, and then it comes up and it goes higher than it did the estradiol than in the first half, the follicular phase, in the second half, the luteal phase. I'm trying to do that by a little bit upping my estradiol in the second half. Oh, and then I'm trying to do like one day where I just do a triple dose, but just for one day, or double dose. I'm still working on it.
So you start off with a lower dose. I mean, you're using the creams, the compounded cream. So you have, I'm not sure how many milligrams you're taking.
Well, this is going to be so individualized. That's why I don't remember. I can give the same dose to like 10 women and they all have 10 levels.